one thing is okay and also think the other thing is okay. Yeah, I could go do that, or I could go do that. Very ambivalent. Okay, so worldwide, it's about 1% of the population. There's really no demographic differences between race, social status, culture. Comorbidity, substance abuse disorder in nearly 50% of these clients. And a high rate of nicotine dependence. Depression, anxiety, suicide, all also high rate of comorbidity. And they also have more health problems. Clients with schizophrenia are more at risk for a premature death. Some of that they think is attributed to their apathy, not caring. You see this flat affect, and so they may not be doing the things to take care of themselves, which could contribute to that premature death rate. And then also the habits that they have could contribute to premature death rate: smoking, drug or alcohol use, not exercising like they should. Physical, other thing you often see that's pretty unique with schizophrenia is the polydipsia, with 20% of the clients, a really insatiable thirst, unique to this disorder, disease. Etiology, it's on page 203 in your book. If you have a first degree relative, your risk for schizophrenia goes up 10%. It's estimated that the genetic involvement is like 65 to 80%. Then remember, almost all of these things we talked about, we looked at the genetic possible causes and the neurobiologic possible causes. And like I mentioned earlier, there's the dopamine theory, that there is disruption in their dopamine levels that are contributing to this disease. So remember all your neurotransmitters carrying the messages. Dopamine is one of them. The first generation antipsychotics' main goal is to block the dopamine. And with that, cut down on those symptoms of hallucinations and hearing voices. And then we said the second generation came out and they worked on the dopamine, but also work on the serotonin level. So there's a theory that it's not just the dopamine that's causing this. The serotonin obviously has some sort of a role to play, or else those meds wouldn't impact it. There's numerous brain structure abnormalities. When you look at someone with schizophrenia, the brain is actually physically structured differently. Other etiology, other factors. They think that maybe there are some prenatal factors, like if the person's father was over 35 years old at the time of conception, there tends to be a higher rate there. They're considering that maybe folic acid levels when the mother was pregnant might have had something to do with it. And remember, we talked about folic acid in maternal child. If the level's too low, it leads to the neural tube defects. So it kind of makes sense. There may be a virus, a herpes, or some other viral infections that the mother might have had when they were pregnant with the person that could have contributed to it. If the mom had some type of really bad psychological trauma when they were pregnant, say like the death of a very close loved one. They've looked at that as a possible risk factor. So you're pregnant with this baby and you have some real traumatic event. Also, interestingly enough, people born in late winter and early spring. So, I mean, you can look at when they're born, or I guess you could go back and see when they were conceived, but there is some, it's in, you know, just some of the risk factors. So you can tell they're just looking at everything and finding a few trends. Toxins, environmental stressors. They've looked at some environmental toxins, even looking at the lining of like the pipes that water systems are in, and that some of the toxins that may be in the water could be contributing. And if you were growing up and you had a stressor at a real key developmental point in your life, you know, we talked about those developmental stages, and so there is some risk associated with trauma as a child at a key developmental stage. And these are all in the Barcarolla's textbook. So talking about the stages, this is on page 204 in your book. The acute phase is usually the disruptive phase, and they usually end up in the hospital. There's the stages. So you try to get them in, you get them stabilized during that acute phase, and then you work on continuing the stabilization. And you're trying to get them back to their previous level of functioning, or as close to it as you can get. That's your goal. And then maintenance phase. And then you see in the stabilization, we talked about a group home or something may be needed. They may go in the hospital, end up with the diagnosis, get them on some initial meds, try to get them stabilized, move them into some sort of a group home or some step-down type living arrangement. And then maintenance, you've got them as close to pre-morbid or back to their previous state as you can. Their symptoms are absent or diminished is the goal, and the level of functioning allows them to live in the community. And that is the phases. And is that always the way it goes? No, but that's the overarching phases and your goals for the treatment. So let's talk about the symptoms. You saw that popping up on the video. When the clients would be saying something, it would come up and say a positive symptom or a negative symptom. But these are the four main groups of schizophrenia. And all of these dimensions impact the person's ability to function at work, relationships, self-care, their ability to function out in society. So when we say positive symptoms, what are some of those? Delusions, no. These are things as positive because they didn't have them before. This is something added to them. So hallucinations, seeing things that aren't there. Delusions are those incorrect, fixed beliefs. Delusions of grandeur. Queen called me, needs me to do some work for her. That's a fixed delusion that I have. If you try to tell me, Miss Lyons, now come on, the Queen didn't call you, I will argue with you, and it is a fixed belief. I'm not going to say, oh, okay. No, I'm going to be like, no.
She did.
I can't help it if you don't understand. And matter of fact, if you try to argue with me about that delusion, it may make me dig my feet in even more and believe it more. You know, So delusions are fixed. Hallucinations are when I'm seeing things that are just not there, or I'm hearing things that are not there. And then the bizarre behavior and that disorganized speech. You saw that on the video. Like the patient I told y'all about that told me about the cheese on the moon and the man on the moon and telling me all that stuff, and then just stopped and asked me about the DOTS in my eyes. And I was like, what's that? And he was like, dots. Did I tell you? Yeah. So he was very disorganized. And he was like, everybody knows. And I was like, oh, okay. That was in nursing school. Very disorganized speech totally threw me off. I had been listening to him talk like that for an hour or two. You know, man on the moon and it's green, it's made of cheese, and sometimes I go to the moon, blah, blah, blah. And then all of a sudden, wow, you got DOTS in your eyes. And I'm like, oh, trying to do some therapeutic communication. Tell me about that. I mean, what are DOTS? Dots. But anyhow, so those are your positive symptoms. And that's what those first generation antipsychotics work on. Okay, they can help with these positive symptoms. Haloperidol, it just always comes up. Haldol comes up. And so if you've got a patient who's got drug-induced hallucinations and out of control, you may give these first generation antipsychotics to that client. They may not be antipsychotic, but you may give them a dose of those meds to try to help. They may be having hallucinations from other things. But this first gen works on these. Now the negative symptoms, what are some of those? Right. Those are things they've lost. Those are things that they've lost because of the schizophrenia. They used to not just sit there and talk real blunt about, yeah, I need to get a job and I want to go back and I want to kind of commit suicide, that flat affect. They used to have, if they were talking about something like that, there would have been some emotion involved, you know? They were just talking about some really serious stuff, and did you see any emotion? So they've lost that. They got that blunted affect. Alogia, poverty of thought, just not able to do some abstract thinking. Loss of motivation, and an inability to experience joy. That is so sad. Affective symptoms, their affect. How does that come across to you? Dysphoria, just dissatisfied with life, just not very happy with anything. High risk for suicidality. A lot of suicidal thoughts. You heard it come up with one of those clients, and just hopelessness. Cognitive symptoms, and those are, we talked about what we think. Inattention, easily distracted, unable to think clearly and logically. Just very disrupted thought processes, poor decision making, all those kind of executive skills. So when you're assessing this client, you're going to be looking for the positive, the negative, their cognitive, and their affective symptoms. And again, what we said before, delusions are false fixed beliefs, and concrete thinking is an inability to think abstractly. You can kind of test for concrete thinking by saying, tell me about, when I say the grass is always greener on the other side, tell me what that means to you. Abstractly, most of us will be like, oh, well, that means, you know, you don't want to be jealous about him. what somebody else has, because it may look better to you, but when you get over there, it's not better. That's what a concrete thinker or someone unable to think abstractly would say, well, it just means that the yard over there has greener grass than this yard. So, and the way that they'll evaluate for that is using, and sometimes you'll deal with people just day-to-day life that have different levels of concrete thinking. Some people are real, you'll hear it described as they won't think out of the box, and that's just a level of, of concrete thinkers. It doesn't mean schizophrenia, but. So, continue with the positive symptoms, these alterations in speech. They're on page 206 in your book. Neologisms are things they just made up. Be words and they're just made up, or they used a word that exists to mean something totally different. Echolalia is when they repeat. We kind of covered some of this with
Majority of it's in ATI on page 80.
on 80, yeah, and that is good. ATI is good for studying these. Thank you. Echopraxia, and that's copying somebody else's body movement. So you can imagine being a nurse if you're caring for this person, and I use my hands and I'm trying to do this, and the patient's just copying what you do. That's just part of this. That's just a symptom. They're not picking or something. It's a symptom. Clang associations, sound, repeating words or using words that have the similar sounds. All I can think is clang.
Right.
Clang, gang, bang, bang. You know, and then they'll just
Yeah.
start talking with a series of words that have kind of sound the same and tend to have noise type words. And then word salad. I think Miss McGee did some word salad in the lab the other day. And that's just a jumble of words. No association at all. Finish this. And they have alterations in perception. The depersonalization, they kind of just feel like the surroundings are not real, that they're not a real person. Derealization, that what is, derealization is they're convinced something has changed big. Their environment has changed. Hallucinations, again, nothing there, but they see something. And when we talk about hallucinations, the auditory hallucinations, when we did the hearing voices, that's what we're talking about there. Command hallucinations, y'all had some of those in the hearing voices where it's telling you to do things.
Mm-hmm.
The command hallucinations are the really scary ones, and they're the ones you really have to monitor close with your patients because they may be telling them to act out violently. And after doing hearing voices, you can, maybe after a while, those voices keep telling you to go over there and punch that nurse in the face. You might just walk over and punch that nurse in the face because the voices are telling you over and over again. And then visual hallucinations, you know, you're seeing things that just aren't there. They also have boundary impairment. You know, we all have our space that we really don't like people to be in. It's usually around 11 inches. They've lost that perception of boundaries, and so they may be like right up in your face. And if you're here drinking this water, I just may pick up your water and drink it, not because I want to drink your water, but just because I think it's in my space, it's mine. So there's boundary issues. So you're working a mental health unit, and you're getting just court admits and people that come in through the ER, and you get a schizophrenic client, and they have these, you know, perceptual issues, and I have a real problem with boundary impairment, And then I walk up to the antisocial personality disorder that got admitted over the weekend because they got in a fight, brought in by the cops. You can see how me not understanding not to be in that person's space could really cause a lot of problems. So you need to keep me away from that client, because that's not a good combination. That milieu therapy, doing a good assessment on your client and understanding where they could be vulnerable to antagonize other people or trigger other behavior. So with that, we'll take us a quick break. Be back at about 5 till. 5 till.
Give them a handle out of that
So for tomorrow, if we've already done the hearing voices, do we still need to be here at 9 o'clock?
Yeah. Yeah, because with lab, the whole time counts towards your class. That's like when you're doing test offs, even though you've tested off, you still have to be in the facility. So yeah, even if you've done hearing voices, you have to be.
We don't have class then. We got all weekend and a few extra days to study for it, so.
Great, thank you for remembering.
Okay.
Usually go 2 pay grades, but
College is the best way to do it.
it's not the first thing.
Oh, you need to be a doctor. Yeah, HIPAA violation.
Oh, girl, it's called old age.
That's good.
If anybody in here is going to Garden Park with me, I've lined up that packet, all the papers you need to sign for Garden Park on this table. So at some point, grab you one of each of those, maybe at lunch, and sign them and staple them and just put them back on the table so I can run those by Garden Park.
Is there anything you need to the South Medical, whatever?
South Miss, no, you don't need to sign or do anything.
They don't want to.
Huh?
I don't know if it's good or bad.
Let me do it first and then. Okay, yeah. One of each on that whole row. And you've already done your drive through in the background.
We got it here.
So, the ones of us that are going to Singing River, since there's two separate floors, are we gonna be separated or will we be all together? Since there's two separate, units, are we gonna be separated or will we be all
You'll be
together?
separated. And a lot of times it just depends on what that census is.
Well, I know yesterday there was only two on, level 1, on first floor.
Oh, really? Yeah, it's just really, they can be 16 of them and
And then one day be 2.
same upstairs, you can walk up there sometimes and y'all work there.
That happened to us at Mary. We went up there one time last semester and there was, I mean, not on the mental floor, but on the floor, regular floor, one day there was 14 patients and we come back the next day and there's 3.
Yeah.
We were like, oh my, they're messed up.
Our dang.
Oh my goodness gracious. I just wanna go to sleep now.
The bigger guys that can probably pay you, they just talk shit behind your back.
Yeah, my baby said,
The little guy, they're going to shove in, water. Trying to watch these calls like that.
$40 a piece. And my daughter makes messes too much.
These lights there.
They do. I buy them jugs.
Let me step. Just leave them here, I'll reset. Oh, these are done. Okay, that's done.
Oh, yeah, I know. I don't buy there. The only problem is I hate looking.